All right. So today I'm going to talk to you about when scleroderma gets hard to stomach. And just starting off with a very brief case for you to keep in mind as we go through our lecture today. This is a 51-year-old female with a past medical history of diffuse cutaneous scleroderma complicated by interstitial lung disease, who presents to you for heartburn, regurgitation, and early satiety. She's waking up in the middle of the night, most nights of the week, from coughing, and she's currently taking omeprazole 20 milligrams every morning. So I think as we keep talking for the rest of this talk, I want you to start thinking your mind kind of, what's on your differential? What do you think is going on with her? What tests would you consider doing? And how would you optimize treatment for this patient? And we'll come back to this case a little bit later. So this is an overview of my talk today. We're going to go into a little bit about the different types of scleroderma. We'll talk about an overview of the GI involvement in scleroderma. I think it's difficult to talk about everything in 20 minutes. So today we're just going to focus mostly on the esophageal and gastric involvement in scleroderma. So you're going to see hear a lot of terms kind of thrown out there: scleroderma, systemic sclerosis. Oftentimes they're used interchangeably. And scleroderma is really an autoimmune disease characterized by a fibrotic process that affects the skin and or numerous internal organs, and that includes blood vessels, GI tract, lungs, heart, kidneys, muscles, joints. And as you see in this chart here, so scleroderma is kind of this broad term. 2/3 of the scleroderma patients have what we call localized scleroderma. So that's where the process only affects the skin and the structure directly underneath the skin. So for example, the muscle. And then the other 1/3 of scleroderma patients have systemic sclerosis, or what we call systemic scleroderma. And these are patients where the process affects the connective tissue in many body parts. And among the patients with systemic sclerosis, about 50% of them will have limited cutaneous scleroderma. So these are patients with skin thickening that's less widespread when compared to diffuse cutaneous scleroderma. And they do tend to have internal organ issues, but the internal problems are less frequent and tend to be less severe when comparing to patients with diffuse cutaneous scleroderma. In terms of diagnosis of scleroderma, you're going to see some autoantibodies checked usually by the rheumatologist. That includes ANA, anti-centromere, anti-CL70, and anti-RNA polymerase 3. And I think the important thing to keep in mind is that these autoantibodies are not always positive. So the most important part of the diagnosis is also still the history and the physical exam that's done by the rheumatologist. And, the GI organ is actually the most common internal organ complication of scleroderma. So GI involvement actually happens in at least about 90% of patients with scleroderma. So we do see this often. In terms of the pathophysiology behind GI involvement in scleroderma, there's been various proposed mechanisms. There's thought to be a component of vasculopathy where endothelial cell injury leads to recruitment of inflammatory cells and profibrotic macrophages. There's thought to be a neuropathic process. So they've identified these M3R autoantibodies. So these are antibodies that's targeted toward acetylcholine receptors. And it's thought to cause a dysfunction of the neuromuscular junction. It's also thought to be a myopathic process where you have smooth muscle atrophy. And there's also a fibrotic process. And all of these mechanisms all eventually lead to kind of the end outcome of what we're seeing clinically, which is oftentimes a GI tract dysmotility. And scleroderma is really one of those things that can affect all of the GI tract, right? Essentially from mouth to anus. So, starting from top to bottom, so it can affect the oral pharynx. These patients can have reduced oral aperture. 50% of these patients can have salivary hypofunction. 25% can have deglutition dysfunction. Up to 90% of patients will have some sort of esophageal involvement. So kind of from a pathophysiology standpoint, what you tend to see is a reduced or absent peristalsis of the smooth esophageal smooth muscles, a hypotensive lower esophageal sphincter. You can see delayed gastric emptying in up to 80% of patients. And then you can also see small bowel dysmotility in about 60 to 80% of patients. Scleroderma patients can also have colonic dysmotility and also a hypotensive internal anal sphincter. So if you think, how those mechanisms translate into symptoms, in terms of the oral pharynx, scleroderma patients are at increased risk for increased periodontal disease, sicca symptoms, and increased aspiration risk. When they have esophageal involvement, they're at much higher risk, and what we frequently see is GERD, which can present as esophagitis, peptic stricture, Barrett's esophagus, adenocarcinoma. They can have dysphagia and endodynophagia. And when they have gastric emptying delay, they will have symptoms of gastroparesis. And also important to remember that scleroderma patients have a higher prevalence of GAVE, so up to 22%. So that's something that you may see on your endoscopic exams. And when they have small bowel dysmotility, they're at increased risk for developing small intestinal bacterial overgrowth, and you can also see intestinal pseudo-obstruction. And when they have a colonic dysmotility, you can see either constipation or diarrhea. Sometimes the diarrhea may also be due to a constipation with overflow diarrhea. Sometimes there's a component of small intestinal bacterial overgrowth that's also contributing to diarrhea. And because these patients also can have a hypotensive internal anal sphincter, they are also at higher risk for fecal incontinence. So I just want to start to then focus a little bit on the esophageal involvement in scleroderma. So the esophagus is actually the most, even among the whole GI tract, it's the most common GI organ affected. And there tends to be more esophageal involvement in diffuse systemic sclerosis compared to limited systemic sclerosis. Esophageal disease does tend to correlate with the duration of systemic sclerosis and also the lung disease or fibrosis severity. And some of the symptoms that you may see are reflux symptoms, dysphagia, odynophagia. And it's important to remember that there is a very high prevalence of esophageal disease in asymptomatic patients. So when they looked at this in studies, they saw that when scleroderma patients are evaluated by an upper endoscopy, up to 80% of asymptomatic patients will have evidence of reflux esophagitis or dysmotility. So for example, when we do our endoscopy, sometimes what you can see in these patients is a lot of retained kind of foamy secretion in the esophagus. And that usually indicates to us that there is some sort of underlying esophageal dysmotility or any distal obstruction. Reflux also often presents early in the disease course, unlike dysmotility issues. And it's also usually on imaging, whether it's CAT scans of the chest or abdomen or a barium swallow. Oftentimes you're going to see a dilated and patulous esophagus. So GERD is something that is very prevalent in scleroderma patients, and it's really important for us to identify, think about, and treat GERD in scleroderma patients because GERD is associated with higher prevalence and rapid progression of interstitial lung disease. And this is thought to be most likely due to repeated microaspiration of gastric contents into the lungs. So there are a couple of ways of diagnosing GERD. When you do an endoscopy, if you're already seeing LA grade C or D esophagitis, then that in itself is diagnostic of GERD. You don't need to necessarily do another pH study to prove GERD in that situation. The other pH, or you can do, if you don't see LA grade C or D esophagitis, you can do some sort of definitive pH test to answer the question of whether they have GERD or not. So you can do a Bravo pH test or a catheter-based pH testing. In terms of treatment for acid reflux, there's lifestyle treatment that includes avoiding alcohol and tobacco. Smoking is actually the only environmental toxin that has been linked to increased severity of GI tract symptoms in systemic sclerosis patients. And I think this is what we tell a lot of our patients as well. You want to introduce gravity back into the equation, right? So you tell them to sit upright for at least 3 hours after eating a meal, head of bed elevation at night. I generally find that having the patients use a wedge pillow is much more effective than someone just using like multiple pillows, because a wedge pillow tends to elevate the thorax, the chest better. You don't have to necessarily get pH testing at the beginning on everyone. So if they're reporting reflux symptoms, it's absolutely okay to start empiric treatment with H2 blockers or PPI. Generally, if they are on PPI twice a day, you want to consider twice a day PPI if they also have nighttime or evening or nocturnal symptoms. If they have breakthrough symptoms despite using PPI twice a day, then you can consider adding on an H2 receptor antagonist at bedtime as well. If the reflux symptoms persist, about up to 40% of patients actually don't respond to PPI treatment. So, in kind of more refractory cases, if they still have breakthrough symptoms, you would consider doing pH testing to see A, if they truly have GERD, and 2, if their GERD is actually adequately controlled by their current acid suppressive regimen. The other thing that you want to think about is ruling out any dysmotility issues, any, esophageal obstruction like peptic stricture that may be contributing to the issue. Clinically, this has not really been studied in systemic sclerosis, but, especially in the more refractory cases, you could consider also using dexlansoprazole if the normal PPI twice a day is not working. Dexlansoprazole is kind of a more delayed release PPI. And, usually in these scleroderma patients where they may have stomach dysmotility, small bowel dysmotility, the kind of usual timing of PPI 30 to 60 minutes before a meal may not be as dependable or get you as dependable of results in scleroderma patients. So it is something that you can consider. Alginate therapy like Gaviscon is something that you can also add on for patients still with breakthrough symptoms. You also can consider stricture dilation if the patient also has dysphagia in addition to reflux symptoms. So these are some of the other medications that have been looked at. They've looked at buspirone actually in systemic sclerosis patients with reflux. Buspirone has been shown to increase lower esophageal sphincter resting pressure, and we know that it also improves fundal accommodation. So when none of these studies in systemic sclerosis patients are very big, but when they looked at about 30 scleroderma patients, it did show that buspirone improved reflux symptoms including heartburn, regurgitation. Baclofen is something you can also consider. Baclofen increases the lower esophageal sphincter pressure and also inhibits transient lower esophageal sphincter relaxations. So sometimes can be used for more refractory reflux. It has not specifically been studied in systemic sclerosis patients, but it is something else to consider as another tool in your toolbox. Sometimes patients, they have very refractory symptoms and we may need to consider more surgical options. So fundoplication, especially for scleroderma patients, because they often have esophageal dysmotility, the surgeons oftentimes will consider doing a partial fundoplication like a door or toupee fundoplication. And Roux-en-Y gastric bypass is another option. And it's an option that we usually consider in particular if they also have gastroparesis. So in terms of involvement of the esophagus, esophageal dysmotility is also something that you'll frequently see in scleroderma. The best way to diagnose it is with high-resolution esophageal manometry. And as you see in this picture here, on your left, you have a picture of a normal swallow or swallow in a normal patient. They initiate the swallow and there's that nice peristalsis of the esophageal smooth muscle. On your right is usually what you would see typically on esophageal manometry in a scleroderma patient. So they initiate a swallow and you see there's normal contraction of the esophageal striated muscle, but there's aperistalsis of the esophageal smooth muscle, and they also have a very hypotensive lower esophageal sphincter. Again, for treatment of esophageal dysmotility, a lot of the same lifestyle things that we recommend for treating reflux also applies. And then the other thing that we usually think about is potentially adding on some sort of prokinetic. So, the data for this is not that strong. I've listed metaclopramide and domperidone here because these are the two medications that have been studied in systemic sclerosis in terms of, whether they improve esophageal motility or not. And I think long story short is none of the prokinetics have been shown to significantly improve esophageal motility. Metaclopramide has been shown to increase lower esophageal sphincter tone, but there's been some conflicting data on whether it improves reflux symptoms or not. Domperidone also increases lower esophageal sphincter pressure, and it has been shown to reduce frequency and severity of reflux symptoms, but that's not something available in the US. So I want to move downwards a little bit toward the stomach and talk a little bit about gastroparesis. So symptoms of gastroparesis includes early satiety, postprandial nausea, distension, vomiting, bloating, and abdominal pain. I've highlighted early satiety and postprandial nausea here because those are the symptoms that correlate the best with gastroparesis. And as you know, gastroparesis, when you have gastroparesis, it can also worsen your reflux symptoms. A couple of ways of diagnosing it. I think most frequently we do a 4-hour gastric emptying study, and you can assess both liquids and solids, which increases the sensitivity for detection of gastroparesis. You can do a wireless capsule motility testing or smart pill, which has been shown to correlate well with a 4-hour gastric emptying study. And some places also do carbon label radioactive breath testing. The other thing to consider in your scleroderma patients is sometimes there's symptoms of bloating and distension. That may sound like gastroparesis, but it's also important to keep small intestinal bacterial overgrowth in mind for these patients. So in terms of treatment for gastroparesis, lifestyle modifications include small frequent meals. We tend to recommend low-fat meals. You want to review their medications to make sure that they're not on anything that would really slow down their GI motility even further. So like opiates, they can use antiemetics as needed. And then really the big category are prokinetics. So I put some prokinetics on this chart here that's split up over this slide and the next slide. So there's metaclopramide, domperidone, and erythromycin. For metaclopramide, none of these things have specifically been studied for gastroparesis and systemic sclerosis. Like, for example, metaclopramide, the data is all from diabetic gastroparesis. But, metaclopramide has been shown to improve gastric emptying. But the main problem with it is it's not a good long-term option due to the potential side effects of tardive dyskinesia, its QT prolonging. So that's the downside with metaclopramide. Domperidone, again, available in Canada and in Europe. It's a QT prolonging drug. It has been shown also to improve gastric emptying and to help with gastroparesis symptoms, but it's not something available here. Erythromycin is a motilin receptor agonist that's also has been shown to improve antral contraction, improve gastric emptying. The biggest downside to erythromycin is the high rate of tachyphylaxis. So, it's something that we sometimes use, maybe inpatient for short-term as rescue therapy, but also we generally don't consider as a good long-term therapy. So prucalopride, like what Dr. Sederat was talking about before, is kind of the newer kid on the block. It's a selective 5-HT4 receptor agonist, and it's been shown to improve gastric emptying and small bowel transit. So it's overall very safe because it's a selective agonist, and the main side effect just includes diarrhea, abdominal pain, and nausea. Pyridostigmine is a cholinesterase inhibitor. There's not much data directly on pyridostigmine and gastroparesis. A lot of this is extracted from the neostigmine data, but it is thought to potentially improve gastric emptying, although we think the effect is not as strong as something like prucalopride. Potential side effects includes diarrhea and abdominal pain. So sometimes we use pyridostigmine as an adjunctive therapy for example, to prucalopride, or for if someone can't use prucalopride. Buspirone, mirtazapine really are not prokinetics. I just put it here to kind of include things in one slide. Buspirone and mirtazapine are serotonin receptor agonists, and they both work to improve fundal accommodation. But I did list it here in this chart so you can remember to, again, keep it in your toolbox for treatment of gastroparesis. Like what Dr. Sutter was mentioning in his talk, it's thought that people with gastroparesis may have impaired fundal accommodation. And mirtazapine has also been shown in some animal studies to improve gastric emptying. So, these are things that I would consider for use in gastroparesis patients, especially if they are reporting symptoms of early satiety. And these are some other treatment options for gastroparesis, including jejunal feeding, parenteral nutrition, Botox injection, pyloroplasty, and GPOM. GPOM has actually there was a recent study that was where they reported doing a GPOM in a few patients with systemic sclerosis who had a significant symptom improvement at 6-month follow-up. And Roux-en-Y gastric bypass is another surgical option. So take-home points. Remember, there is a very high prevalence of GI involvement in systemic sclerosis patients, up to 90%, and it especially involves the upper GI tract. Many scleroderma patients can be asymptomatic, so you really want to consider treating or testing for acid reflux and gastroparesis, especially in patients who have declining pulmonary function. You can start with empiric acid suppressive therapy for patients with reflux symptoms that includes BID PPI plus or minus an H2 blocker. You can consider pH testing, gastric emptying study, and prokinetic use in more refractory patients. And for gastroparesis, symptoms can be subtle, so you want to have a high suspicion for it. You can treat with lifestyle interventions, antiemetics as needed, prokinetics, enteral feeding, or possible surgery. So, just in the last 30 seconds, going back to our case, I think, this is someone where I would consider, given her heartburn, regurgitation, clearly that's consistent with reflux symptoms. I would at least change her omeprazole to twice a day and potentially adding on an H2 blocker at bedtime. Her early satiety raises suspicion for gastroparesis. So this definitely is someone who I would do a 4-hour gastric emptying study on. And if that's positive, then you can consider treating with a prokinetic, which should then also help with her reflux symptoms. All right, that's it. Thank you, everyone.